We need a paradigm shift in orthodontics to go from straight teeth to a beautiful wow smile and facial aesthetics and still keep the occlusion wonderful. And so it's a lot. That's why it's not just passion, but it takes a lot of skill. That's why we try to train these people.
Hello there, everybody, and welcome to another episode of the Orthopreneurs podcast. Today, I feel honored and humbled. Somebody who I respect a huge amount, and many of you respect as well a lot, is my guest. He really needs no introduction, but I'm going to give him one anyway. He's really, I think, one of the greatest educators and innovators in recent orthodontic history. And put your hands together for the amazing Dr. Tom Pitts. Welcome, Tom.
Thank you so much, Glenn. Glad to be here. And thanks for the compliments.
They're well earned. And I could go on and on for a lot longer, but it really is a joy for me. People ask, why do you have a podcast? For me, one of the greatest parts about doing this is the ability to interact with people like you and ask the questions that are on my mind, that are probably the questions that a lot of other people have. And it's truly a joy and a pleasure for me to be able to walk away from these sorts of interactions, a better orthodontist, and in many cases, a better person. So I'm really looking forward to some time with you today.
Thank you very much, Glenn.
Let's start, if it's okay, like I do every interview. And if you want to take some time and in as much or as little detail as you like, how did you end up where you are today? I mean, what's your journey in as much detail as you want to go into?
Well, that's a big question and a good question, Glenn. When I was in dental school, my senior year, I was going to apply for a prosthodontic residency, because I really loved, especially the aesthetics and also the occlusion. In fact, we were talking earlier, but I was on a Stewart instrument my junior and senior year for occlusion because we had one instructor that was really good there.
And most people don't even know. I'm just stopping you for a second, Tom, because I got to work with a Stewart articulator back in the day. For people who don't know better, a Stewart articulator is a fully adjustable articulator that oddly enough was invented for dentures, was what it was originally made for. And for those of you out there who've never used one, they are beautiful because you can do custom ground fossa boxes, you can do fully designed Bennett shifts, and all those things that all of you listening right now are so thrilled you never need to do. And so working on a Stewart articulator raises your street cred with me instantly, if it's possible, Tom.
Yeah, thank you. But anyway, that same senior year, Art Tagoni came back from ortho program and taught us orthodontics as a senior dental student. And so by the end of the year, I scrapped the prosthodontic residency and decided to go into orthodontics. Art said, you'd be better off if you practice 2 years and you'll be a better orthodontist. So I found an associateship in Reno and worked there. Of course, I grew up in Reno, Nevada, and I had patients instantly. But then I was in about 4 months practice in 1970, and I got my draft notice with Vietnam kicking up. And so I went into the Army and served 2 years in the Army. And it was really a good experience. There were 52 of us that came to Fort Carson, Colorado. And I learned from all of these. I thought it was hot stuff, but it was really a good learning experience. But anyway, I applied for ortho and went to University of Washington. And University of Washington was into finishing occlusion, and they wanted their occlusions perfect and the tooth positions. They felt that everybody at University of Washington felt that functional appliances didn't work. And so when I was dealing with class 2s and skeletal class 2s, I didn't have much choice other than headgear, extract upper 4s, or surgery. From there, I started practicing in Reno, Nevada. The first thing I did was I started going to every course I could possibly go to because I had a thirst to know as much and to do as much as possible. the first course I went to was a Roth course. He was setting up his first course at University of California, and I was in the first class. He set it up for the instructors at University of California ortho program, and they needed 4 extra ones, and so I snuck in there. And it was a really great experience, just associating with the people that participated in it, as well as Ron Roth, and of course, occlusion was everything. And Ron extracted, I'll bet 80% of the time, and of course, he mounted every case and did a hinge axis positioner, and then adjusted the occlusion, etc. Then in 1970, but I went to every course I possibly could. Then a year later, I had this young man come in. He was 7 years old, and he had no condyle on the right side. And so his jaw was way off to the right, and he had no mandible to speak of. The other condyle was short. So I just read an article by Dr. Harvold down at the University of California, and he was showing what he was doing with the activator. And so I took this young man and his mother down to University of California, which was only 3.5 hours from Reno at that time. He proceeded to make this functional appliances that was very asymmetrical, brought the mandible to the left and opened it and brought it forward. And I only followed the youngster for 3 years. But then what happened was that the condylar process grew right up into the fossa. He had a chin, and it was almost miraculous what I saw. So even though functional appliances didn't work in Seattle, they apparently worked in San Francisco. So I started studying that and started working on facial aesthetics, particularly for class 2s. But then in 1974, I went to the Ricketts Continuum, and Ricketts was probably the biggest influence in my thinking of any of the courses that I've ever taken. And he was into light forces. Roth was using 8-ounce rubber bands, and Ricketts was into real light forces, non-extraction. As much he split up the arches. He used an 018 appliance, and he widened arch wires, if you can imagine, because that was a no-no at University of Washington and probably in many universities around the world. Anyway, that was a huge influence. So I started to see that I could break some rules that I was taught, and that kind of stirred the creative juices.
So are you saying that back then you were a bioprogressive kind of guy? You were working bioprogressive?
I was.
Yeah.
Uh-huh.
I was lucky enough to learn that in school from one of our faculty. And it saved my bacon more than a few times along the way.
Very good. Very
yeah,
good.
I mean, the way Ricketts looked at things was truly, I mean, for
Yes.
you, these are great stories that you got to hang out with Ricketts and Roth. And I mean, Arnold, Degoni, Art Degoni. I mean, like, these are people that I've read their things. I've never met them once. And yet we owe so much to these people for
That's so
the
true.
foundation they created. And I'm loving the story. And so, yeah, to have practiced bioprogressive, which I'm sure a lot of people listening have practiced that style, and then now where you are is an amazing journey. So I'm sorry for interrupting. I just needed to get verification that you're actually practicing with, overlays, utility arches, and those sorts of things, Z arches, and all these other fun things that Ricketts created. So, yeah. So sorry for interrupting, but
no, that's great.
After
you're right on.
You finished with Ricketts, and you're on your journey still.
Yes, and also Ricketts was into square wire. He loved the 1616 square, and so anyway, I got to enjoy that square wire when I was working with torquing and just the lightness of the force. I started doing a lot more non-extraction work, breaking up my arches, using the bioprogressive and that sort of thing, and widening arches. And of course, IPR was a much more extensive than what I'd done before. And so I had to combine that with making sure I got the right functional occlusion. It was, I think, 1983 or so. Did the beta testing with Ormco when they had the lingual appliance. They introduced it, and I was in on the beta test. And so I strapped up about 25, 30 cases. And what I saw, well, if I can backtrack, Rick had said never use a removable upper bite plate because you'll have lack of posterior support. And so I never did. But when I put the lingual appliances on, of course, I had bite turbos behind the centrals. And so what I found out is that it actually decreased the symptoms if they had any symptoms because of the proprioception of the material on the teeth. They weren't clenching. It was kind of like a splint. And so that's when I started using disarticulation. And then I started playing with disarticulation. And on all deep bites, I put them behind the centrals. And of course, some of them had to be real long if they were a little class 2 and opened a little more class 2. And so we eventually started putting them on the cuspids, but then the cuspids aren't always erupted. And so we went to the first bites on deep bites, and it's kind of continued that protocol. But I don't leave them on the bicuspids. Once I get to the 2020 night tie, then I shift them to the centrals again, because I've already started the early rubber band treatment, and very light rubber bands. And when I went to passive self-ligation back, it was in the 1985 area, I tried this passive self-ligation from a company. What I saw there was I was getting early widening. And so if they were a little crowded, I didn't get too much proclination of the anteriors. And so it was easier for me to do more non-extraction with passive self-ligation. So that with the bite turbos and then the immediate light elastics, because with passive self-ligation, I went down to 2-ounce rubber bands to start with and didn't get much above 3, except on some class 2s, I'd use 4 ounces. And there's 3/16, they're very small rubber bands. So that was kind of the progress there. And then it was around the late 80s when I started out, we only had bands on every tooth. And so when you put bands on the tooth, and I used Larry Andrews' appliance, and what happened is the slot was about in the middle of the tooth. And but as we went to direct bonding, what happened is everybody moved the slot more incisally. I don't know, to keep out of the tissue or what, but we all did it. And so the smiles got worse as we did that. And so I got fed up with that about somewhere in the late 80s. And I started playing with bracket position for smiles. And that's when I started to innovate that. I had to figure a way that if I had a deep bite, how can I still extrude the upper anteriors? And so I just slowly worked out the protocols so that I was intruding the anteriors. I was tipping the occlusal plane a little bit with the bite turbos and rubber bands, and putting the brackets much more gingerly on the upper anteriors when I needed to extrude the upper anteriors. And I was able to achieve excellent occlusions, and then my smile started to look much, much better. And so I kind of kept following that through the 90s. And of course, I was working with Dr. Damon on his passive self-ligation bracket, and I was able to develop some good passive self-ligation protocols. But when I was working in the orthodontic clinic that Cybron set up for me, and that was down in Anaheim. And so I started working with this one wire engineer that I knew, and he made me some good square wire And so here I'm using 2020 wire in an 022 by 028 slot, which of course isn't really 022 by 028, it's larger. But I was able to see that I had so much better force, and I had so much better control of the torque. And so, of course, I was gone for in and out. I had to do a lot of adjustments in and out in the brackets. But then I stopped using rectangular wire and just worked up and went to the square wire. That, of course, led to me now doing a square wire appliance, but I wanted it with less force. So I built the slot in the 6 anteriors, upper and lower, at 21 thousandths by 21 thousandths. And then it goes 21 thousandths all the way back to the second molar OG. But then I extended the buccal lingual depth of the slot as I went back to the molars. So I had more room for expression of width and settling and that sort of thing, which worked out really well. And so I'm really excited about that's a long history, isn't it?
It's remarkable. I mean, again, I always like to tell people, and you heard me say it before we came on, right? I don't come in with a whole bunch of contrived questions. I want it to be two friends sitting, having a cup of coffee, just talking, right? And everybody else listening in. And, if it wasn't for the podcast, I would have legitimately a dozen talking points I'd love to dive down with you because, I went to University of Washington, not for ortho and not for dental school, but as I told you, I did 3 years of ethology training with Jerry Schultz at University of Washington, where we did a 3-year course just in ethology and learning that stuff. And I'll get into that a little bit later, but you rubbed shoulders with the giants of the educational background that we all lean upon these days. And the journey, I mean, the one great takeaway from your story so far, because I know there's more to it, is for those who haven't used a bioprogressive or modified bioprogressive system, they can't really appreciate how radically different in implementation, not theory necessarily, but in implementation, it is to go from modified bioprogressive to a passive self-ligating system, particularly in terms of, you're using a utility arch, which you're using to intrude the lower anteriors, which is exactly what you're doing, with the PSL system. When you take the uppers and bring them down, you concomitantly bring the lowers down at the same time. You're essentially using a modified bioprogressive system, right?
I do. And to that point, I use an extrusive arch on the upper anteriors all the time.
I was about to say you're using it. You beat me to it because you're doing the opposite of what Ricketts would do there. Ricketts would have two intrusive arches to open up, create the couples, and back it up with class 2 elastics to create an overall moment on the system, if you will. Right? Dr. Meister, Malcolm Meister somewhere is about 93 years old. And I love the guy. And he's the one who at the time, we had no idea. Honestly, we sat through his classes on modified bioprogressive and truly had no idea what he was talking about. He was such a patient, gentle teacher of this approach. And it took me 6 to 8 years in practice to truly appreciate all the benefits of what a modified bioprogressive system brings to the table. And if one steps back and looks at what you're doing, it's the same concepts, but just so much easier to implement. Right. Did I get that wrong?
No. And that's where I discovered, because you're exactly right. When we were correcting a deep bite before with whether it was bioprogressive or regular, we intruded the upper, intruded the lower. And what I found when I went to the lingual appliances with the bite turbos on, I didn't have to intrude the upper. That's how I discovered that. And so that was another step, but it was still just a little bit jump from bioprogressive. He was an amazing man. He wasn't well liked in orthodontics because he was pretty gruff and he wanted to debate everybody and their their mother. In fact, when I got out of ortho school, the first meeting I went to, we had the president of the National Angle Society lived in Reno. He was an orthodontist in Reno. So he invited me to this angle meeting, and it was a debate between Dr. Robert Ricketts and Ernie Hickson. And Ernie Hickson was a great guy. He was the head of the program at the University of Oregon. And so his thesis was that, well, you know what Ricketts' thesis, of course, you needed to take all of these tomograms and records and do this analysis and growth projection. And Ernie's premises was just show me the photographs. I thought he was crazy, but I'm more like Ernie now than Rick. So yeah,
That's
good
great.
history.
To a person, every single orthodontist, the best orthodontists that I know, the ones who are consistently churning out spectacular results, irrespective of what walks through their door, to a person, they've all been through the Roth course. To a person. And it's crystal clear that the understanding of occlusion, of the stomatognathic system, the musculature, because you're talking about putting bite turbos on upper centrals, and you're for those people, for those of us who've been through a lot of mythology, it's like you don't even think twice about what putting bite turbos on the anterior and disarticulating the posterior is doing on the musculature, on the joint, right? It's splint therapy, for lack of a better description, but it's so easy to understand what's going on in terms of condylar seating, in terms of masseteric and temporalis shutdown, pterygoids. I mean, all these great things are happening. But my question for you is, because you've got the historical perspective to answer it, why did ortho move away from, well, the question is, was ortho always sort of dissociated a bit from occlusion? Because you took the Roth course, which would make me believe that before Ron Roth got started with the stuff, that it wasn't being taught in ortho programs, because it had been around way before Ron Roth, right? The papers that we've read on anathology and occlusion go back way before him. So was it not being taught in schools? And number two, why is that even to this day, the overwhelming majority of ortho programs do not put a deep, strong emphasis on occlusion and the impact it has on the entire system? So I'm sorry, I know it's two very big, giant questions,
No,
but I figure you can answer that one.
I agree with you that most of the people I train in my master's course do not really know much about adjusting occlusion and what the pathways are and how you get your finest buccal occlusion. A lot of finishes don't even have a buccal occlusion. So I went to Peter Dawson course well after I went to Roth. And Peter Dawson simplified it in so many ways. And so I use not so much a Roth technique, but I use the Peter Dawson technique, and I adjust every occlusion before I take the braces off. Some people let teeth settle. I don't let the teeth settle. I want it perfect before I take them off. And that's what we've been trying to get the efficiency down so we can get this done in a year or a little more as far as our treatments.
But again, going back to the question, I mean, you're pulling out names and people that played such pivotal roles in my life, right? I haven't been practicing anywhere near as long as you, but I came out of school 32 years ago. The Pankey Institute, right? LD Pankey started it. Peter Dawson ended up running it. His red book on occlusion should be required reading for every ortho resident who ever starts a program.
Functional occlusion. And it's simplified.
His book, it's spectacular. And, here I went from doing 32 or 28 teeth in a full mouth reconstruction, whether on implants or natural teeth, and having to understand the occlusion into ortho, where when I talk about anathology, you have people who in the groups who laugh and make fun of and say, yeah, it's a study of articulators and we don't need it. And why, again, going back to the question, why has there been it's our number one, it's our best friend. Understanding occlusion and the muscles and how the occlusion itself plays a role can be our best friend in solving issues. And number two, why is there such resistance from the programs and from our peers, about occlusion? Is it because the bite will just settle at some point and that's good enough? Do we not care about balancing interferences? Do we not care about cuspid rise quite as much? Do we not care about a mutually protected occlusion being the key to long-term stability?
It's like everything else, Glenn, when our teachers were taught by their teachers, taught by their teachers, and it just wasn't in the curriculum. And they figured it would settle in and be fine. So you're absolutely right. I wish there was more involved in these programs for occlusion. The function is critical. Yeah.
Yeah, and the other thing I was going to ask you about when you're telling your story, which is fun, and by the way, Peter Dawson has the greatest quote that anybody who ever teaches should remember, because he said, "When you quote me, date me," right? Because he reserved the right to change his opinion. And because he was the most quoted occlusion guy on the planet for a while, he reserved the right to say, yeah, I used to say that 10 years ago, but I've learned and I've progressed and I've gotten better and I've learned from my mistakes. And now I say this. And, all too often people jump down the throats of people because they said something once 15 years earlier.
Right.
But what you were talking about is centric relation, right? Another dirty word in orthodontics. Just literally in the last week, I had a 28-year-old young lady show up at my office who'd seen 3 other orthodontists. And I want to be crystal clear. I'm nobody special. I'm not any better than anybody who's listening right now. I just have more training in this area. And she came in and she's having a click. Okay. She's having some locking from time to time. She's having some TMJ issues that, let's be honest, most orthodontists today get worried and scared and say, well, we're going to send you to a TMJ specialist before we touch you. I just told her, I said, look, I'll quote you an ortho fee that's going to include a splint at the beginning. Then, we're going to keep you in the splint as long as it takes. Then we'll do ortho and we'll build your ortho to that CR position. Or once we get you into a stable CR through your splint, we'll see if you still even are an ortho candidate or if you need surgery. Because she was almost end-to-end class 2 before putting her in CR. She may need surgery to be able to get her where we have to get her potentially. But again, I quoted her a fee that included a splint at the beginning to treat her and then a splint at the end, which is, I know, really rare in today's day and age. But the concept of capturing centric relation and making sure that it's not changing on us after we've captured it, to me, doesn't increase your liability. It decreases your liability immensely. And again, if I talk about just a fully occluded splint, a horseshoe splint, that's just simple occlusion from one side all the way around to the other with a nice light, mutually protected occlusion in excursions that doesn't exceed the condylar inclination, something that doesn't, distract the joint as we're going left and right or in protrusion, is something that when I speak to my peers, it scares them. They genuinely don't feel comfortable with what I would refer to as one of the most basic of procedures that, again, can save our bacon over and over again. Is there a place today, aside from somebody coming into your office or my office and having one present to show them, is there a place where orthodontists can go to get a really good understanding of occlusion and splints in today's day and age?
Well, I think the only way is to get Dawson's book on functional occlusion and study it. And it's not that complex. And it's funny, I had, when I was working with Ormco, Oliver Gillis is...
I love Oliver.
Yeah, I do too. He was one of the leaders of the company, but his wife had worn a Gelb splint for 8 years, and she had no occlusion in the posterior. she had to wear it 24 hours a day, eat in it and everything else, because if she left it out, it just killed her as far as pain and discomfort. So anyway, she said, can you treat me in such a way as you can close that bite and without going through misery? And I said, well, that's a good question. So anyway, I said, well, let's give it a try. So her anterior overbite was mild. It was only about a couple of millimeters. So I put bite buttons on the back of her upper centrals, and the symptoms went away right away, because of course I had a little split in there, and then I could start working and start working with the occlusion and so I was in about 10 months, and of course the buccal segments were coming together, and now her symptoms kicked up again. So I said, oh, okay. So I put bite buttons on the 6s and 7s, and her symptoms went away again in another few hours. And so I knew that I could work on the molars with that, the bite buttons. So anyway, I took them off the 6s and just left them on the 7s. And then I finished her real beautiful, and I left them on to, and of course I started adjusting her occlusion when she still had appliances on. And then I left the 7s on until I was ready to take the appliances off. And then, of course, they erupted real quickly, and I was able to adjust the bite. And I went to a nighttime connected splint that she couldn't go back and forth with her grinding, and I saw Oliver at the AAO, and this has been 10 years ago, and she's still no symptoms. So we need to know about occlusion and joint and comfort and whatever we need to. That's part of our stuff, and that's why I couldn't get really great aesthetics unless I brought the occlusion along with it. And that's so that I developed these techniques and developed some good techniques for brachyfacial and mesofacial crowded cases that I can do without extracting. And even dolichofacial, sometimes I'll use the buccal shelf screws and stuff to back things up rather than take out bicuspids. And in fact, nice. I haven't taken bicuspids out for quite some time. If required, I'll do it. If the ascending border of the ramus starts right behind the second molar, then I'm faced or forced to go to a extraction.
Yeah, well, you did that great course for Orthopreneurs University that people can still watch.
Oh, good.
At orthopreneurs.com, you did extraction versus non-extraction in flared and crowded cases, which was truly amazing. And I encourage anybody listening, if you want to get CE, you'll get, I think, 5 hours of CE. You can watch it on your own time, and you can really get some great information on extraction versus non-extraction in flared and crowded cases from, Dr. Tom Pitts. And
is that just through you or through YouTube or what?
Just they go to orthopreneurs.com. They'll click on Orthopreneurs University, and there, lo and behold, is your course right in front of them. And I'm always open to having you for more courses down the road and teaching whatever. I'd love to have you, because
I think that's one of the best meetings of the year is Orthopreneurs.
Well, thank you.
That was better than the Ormco Forum.
Well, I heard stories about the original Ormco Forum and things. I'm just going to leave that there. I'm not going to say another word about what happened at the Ormco Forum early on. And by the way, I wish I had one of these podcasts where I had like a research team. So I have to do all the research myself on the fly. I think the passive self-ligating bracket from a company was the Activa system, was it not?
Activa, yeah. Yeah.
There you go. I'm doing the research on my own right here, Tom. I'm just telling you. You mentioned it. I'm looking it up.
I love it.
But that was the Activa was the one you're referring to, right?
Yes.
Awesome.
And you couldn't finish worth a darn, and the doors kept opening up, but it really showed me some real tricks with passive self-ligation.
While we're talking about courses and what have you, I know the Pitch 21 system is the sort of, I wouldn't call the end of evolution, but certainly with you, I suspect there's a process, and there'll be something else coming down the turnpike to make it better. But talk about what the root not story, but the keys, if you will, to the Pitch 21 system. And let's assume that listening right now is an orthodontist who says, I really wish I could finish better. I really wish my aesthetics looked more like what I see Dr. Pitts do. I wish that my buccal occlusion looked better. I'm looking for an answer here. Can you talk about, and to be crystal clear, I have no financial interest in the Pitch 21 system of any kind, so nobody would ever think that's the case. What is it about your system that can help people get to a better finish? What did you build into it, and how does it work?
Well, it's a real system, and it takes not only passion to change into a different system, it also takes skill. And there's so much that goes along with it. It's not just the bracket. It's the bracket position. It's the protocols. It's where you put the bite buttons. It's where you put the bracket, and how to reposition them on that second or third appointment. And it takes a lot of skill and to learn these protocols and how to do it, because I saved 5 or 6 appointments of what I was doing with the rectangular system. And because my second wire is an 18 by 18 square nitai. And so if my brackets are flipped, if I got any flaring or anything, then I have torque lockup happening in the second wire. So it's so much faster as far as control. And then I do widen wires and widen arches. I gain a lot of space there along with the IPR. It's just so beautiful how we can take these brachiofacial and mesofacial cases and keep their teeth really full, do them non-extraction with crowding. The class 2s, we can end up with beautiful upper lip and chin, and I even do it in adults. But anyway, class 3s, we have so much more control. I can flip the brackets upper and lower for 2 to 2, and use the light rubber bands. Oftentimes, I never have to go above 3.5 ounce, 3/16 force, and it's very light force. I start with 2.5 ounce, go to 3.5 ounce, and it just falls into place if they'll wear them. If they don't wear them, I put some springs on, and so we're able to treat these cases beautifully and finish with saving me 6 or 7 appointments, and it's really exciting. Really exciting.
It's amazing.
And of course, I'm like Dawson. Now I'm on my 10th master's course, and of course, my curriculum is a heck of a lot different than it was just 2 or 3 times ago.
It's a sign of a great teacher, right? The course evolves. It changes.
You got to be humble, and you got to change.
You're learning. You're not just teaching.
That's right.
And that's huge. By the way, since we're talking about it, if someone wants to take your master class, how do they sign up for it? How do they learn more?
It's Joni, Joni, Abel, ABEL at me.com.
JoniAbel at me.com. JoniAbel at me.com.
Right. And she'll tell them how to do that. It's a 2-year program. We meet every 6 months. They start 2 cases, and we follow those cases. It's really a great learning experience. We go over everything from A to Z in orthodontics.
As we just start getting closer, to winding down, when I came into ortho, late, right? We all know my story. I don't need to repeat it 1,000 times, but I started ortho in 2012. I started residency in 12. So it's been about 12 years. There were, shall we say, outrageous claims being made by many in the passive self-ligating world. And because, educational institutions often are places of, trying to put brakes on some outrageous claims, understandably. I was sort of, my headspace was spinning about what can you do with passive self-ligating? What can't you do with passive self-ligating? Difference between active and passive. Now I've practiced a few times, right? I've done a couple of cases in the last decade. Do you feel that active self-ligating systems really do restrict the ability to get width in the posterior?
I can't say that. No, I
Okay.
can't say that.
I've heard it said. That's why
Yeah.
I asked.
Yeah. I wouldn't say that at all. I would
Okay.
say, there's certain things with the clips I don't like with the passive systems that I know, or the active clip systems. And I can't put chains underneath the wire and I can't do certain things. But, I can't say that. I see some beautiful cases done with active self-ligation.
Yeah. I just figured I'd ask the master because
Yeah.
if it comes
Thank you.
to self-ligating, you're the guy to ask. In terms of aesthetics, I know you've talked a little bit about aesthetics, and we've talked a lot about function. When you look at a case when it's finished, what's an aesthetic win? I know people are built differently, faces are shaped differently, obviously, and I know there's no one size fits all. But what are the things you're looking at if we want to call it an aesthetic success?
Well, number one, I want perfect inclination of the upper anterior teeth. I see so many cases finished orthodontically that have proclined upper anterior teeth. It's very unesthetic. Number two, I want the right arch form. I built my arch form for aesthetics, for nothing else. And I do widen the arches because I want a 12-tooth smile. So I want that broad in the molars because that, like your smile, it's a beautiful smile, and that's what I want to create. And you have a great arch form. You have everything I'm looking for. But I want the lips to be full. I want the chin to match up. I want the muscles in good shape. I want them in centric relation. I want full incisal display on smile, like you have. I'd die to have that. And I like to
I'm
show a
only
lip.
27 years old, Tom. So give me a few, give
You
me a
started
few more
early.
years as my lip starts to droop in my 30s. We'll start to see my inside.
Yeah,
Sorry.
but I love that full incisal display. So it's not just about smile arc, and you have a good smile arc that with the incisal edges following that curve of the lower lip, and so there's so many cases that are treated with aligners that don't extrude the upper anterior teeth. I can only do aligners on maybe 15-20% of the cases I see because they already have good incisal display. They already have pretty good molar width. But I want to get a wow smile. I don't want just a nice smile. I don't want a flat smile. And that's 90% of uh, orthodontists. We're known for straightening teeth, and this is far beyond straight teeth. And I've been working on this for a long time, Glenn. And I'm really glad that I could be on your podcast and get some information out to the people too, because we need a paradigm shift in orthodontics to go from straight teeth to a beautiful wow smile and facial aesthetics. It's just and still keep the occlusion wonderful. And so it's a lot. That's why it's not just passion, but it takes a lot of skill. That's why we try to train these people. I'm excited. You mentioned Jim Morris. He's starting an orthodontic program at LECOM. And so it's going to be a wonderful institution. And of course, he's very good at all the protocols that we're doing.
And by the way, for everybody out there, when Tom and I were talking before we came on air, I explained to him that when I came through my ortho residency program back in 2012, we were taught, I was taught modified bioprogressive by Malcolm Meister. I always like to give credit to people who deserve it. We were taught how to do Myaw, right? I was fully trained in Myaw by Coro, out of Miami. I feel horrible because I know him well and I can't think of his first name right now. Not Jorge, I don't think. But he taught us amazing Myaw. And we learned our daemon from Jim Morrish, who would drive across from Bradenton every other week and stay in a hotel just to teach us every other Friday how to do your protocol for treating daemon. And again, like many other things, it never made sense to me at the time. Not Myaw did, you look back at my orthodontic residency, I couldn't understand Myaw. I couldn't understand
Are you
modified
talking about the
bioprogressive.
multi-loops?
Yeah, multi-loop edgewise appliances, right?
Yeah.
And
Yeah.
we'd have to bend our own Myaw wires. We'd have to put them in, and he'd come over, very gracious, and help us put the rubber band protocols in. And it wasn't until, again, 6 to 8 years later that it really made sense that how we were really changing the occlusal plane in a drastic way. But hey, you know what? We do that in aligners. We do that with, when I want to take close down an open anterior bite using aligners, where incisal edge is appropriate, where incisal edge is already, preoperative incisal edge is in a good place,
Yeah.
but there's an open anterior bite.
Right.
I'll do the Myaw technique with liners. And I watched Jonathan Nicozisis or Maz Moshiri teach their liner intensive fellowship. And I said, that's a Myaw technique. And he said, exactly. We're doing it. So, it's just amazing to me, the great teachers we've had out there. And Jim Marsh is one of them.
Yeah.
He
Very
he taught
much.
me so much about these things. And, we stand on the shoulder of giants.
Yeah.
And
Well, I appreciate your humility, and that's one aspect of people that I really look for. And so you're a great teacher yourself, and I think the profession is blessed by having you, and what you've done with your meetings and your webcasts, and it's just pretty exciting.
Well, thank you.
Yeah.
It really is humbling to hear that from you, and I appreciate it. And I was told many, many years ago, I'll leave you with this. When I came to Seattle in 1996, I'd already been practicing for about 4 years, and I fell in with what I would say the greatest group of dentists that any human being could fall in with. People, again, I'll give credit to, you've never heard of any of them, most of them. Dwayne Eng, and Henry Nichols, and Tony Santorsla, and Fred Ebsworth. And they were all part of this amazing restorative crowd that sort of followed from Coyce and Spear,
Right.
who were out in Seattle at the time, and Vince Kokich and Dave Matthews, the periodontist, not the band leader.
Right.
And I would sit at a table with these people and we treatment plan together. And I would just keep my mouth shut and my ears open and learn so much from these folks. And Ward Smalley became my mentor. He became my right hand. And those people out there who know Ward, perio, pros, and ortho, triple boarded.
Mm-hmm.
Wound just a little tight. But he looked me in the eye in 1996 when I said, I didn't have kids yet. I said, I really want to learn how to be the best restorative dentist on the planet. He said, I will teach you every trick I know, but you need to pay it forward. Those were his words to me. You need to pay it forward.
Beautiful.
And I think you've clearly done that with your teachers. I'm trying to do it with mine. And I think everybody out there, there's an obligation on each and every one of us to pay it forward in any way you deem fit, especially with the restorative communities really not understanding ortho on any level. Pay forward. What do you do with your GPs in your community? Teach them occlusion. Teach them an understanding of aesthetics. Teach them to look for what's over their head and let them do their Invisalign if they want to, a little bit of it. Let them straighten the single front tooth. But pay it forward. If you don't want to pay it to other orthodontists, in the land of the blind, the one-eyed man is king. So go to the restorative dentist and teach them the basics of what we learn so that people are not getting screwed up. And trust me, there's enough low-hanging fruit out there for all of us. And so anyway, sorry for the soapbox moment there,
I
Tom.
love it. I love talking with you, Glenn. And I just echo what you're saying. I think that's a great way to pay it forward and pay it back. Anyway, I just appreciate our conversation and knowing
Likewise.
you for one thing.
Well, thank you. The last time I saw you in person, I'll leave you with this. The last time I saw you in person was at the 2018 Orthopreneurs Summit. I've seen you at lecture, but I haven't come up to you and said hi. But the 2018 Orthopreneurs Summit, the day beforehand, you gave us a day of continuing education for the Orthopreneurs RD group.
Yes.
At the Omni Hotel in Frisco. And I couldn't really attend it because I was so busy running around trying to get the meeting ready it was our first one. And you had that beautiful Hawaiian shirt on. And I'd sit in for 5-10 minutes at a time. And to this day, that's one of my big regrets is I really wish I could have sat in that room for the entire day rather than run around. But the day will come where I get to sit in a class of yours and just take it all in and just enjoy all the gold that you spin for all of us. And on behalf of everybody listening, I just want to say thank you from the bottom of my heart for all you do for the profession, for all you've innovated, and for taking these incredibly complex concepts in ortho and just making them easier so that people like me can actually get it done. So thank you.
Thank you so much, Glenn. You got a lot more years to go. I love it. You keep it up.
Don't curse me that way. but thank you, Tom, for being here today. And just anybody who wants to learn more from this master, you can get a little primer by going to orthopreneurs.com and clicking on Orthopreneurs University and taking his extraction, non-extraction, flared, and crowded cases, or you can reach out to Jody Abel, right? Joni, JONIABEL @me.com. Did I get that right?
ME, yes.
Well, again, Tom, thank you for being here today. And just wishing you a wonderful day. And I can't wait till I get to see you again somewhere.
Okay. God bless, Glenn.
Thanks.
Bye-bye.